and I look forward to talking to you guys about this. So the first disclosure I should tell you about, so I did create a digital physical therapy company that allows patients to be risk stratified, manage their pain and function at home, and do therapy at their house for orthopedic injuries, and we track clinical outcomes. But I do have a disclosure to let you guys know about. A little background about myself. So I was born and raised in Bethesda, Maryland. I was a previous personal trainer and collegiate basketball player. My background is exercise physiology and biomechanics. I did a joint medical degree and MBA down at Virginia Tech. I did my residency at Georgetown in physical medicine rehabilitation. And then I did my fellowship at Mayo Clinic, the #1 hospital in the world for sports medicine. And then I have a special certification in diagnostic ultrasound, which allows me to save a lot of patients from unnecessary MRIs and to look at an ultrasound in the office and actually go over with the patient with their history and physical exam. And it's a lot more affordable. And I have this certification to be able to diagnose those injuries in the office.
Dr. Gruner, is that the RMSK certification? Is that what that is?
That's correct. That's the RMSK certification. Okay. And only a select amount of doctors probably will go for that type of certification, but it's important for credentialing and for showing that you have the ability to diagnose these injuries in the office. This is where I trained at Mayo Clinic. It was a wonderful place where everyone was salaried, and all the clinicians cared about getting the patient better. And we had a surgery center, physical therapy, orthopedics, rehab, all work together in a holistic way, trying to be innovative and also do a lot of research on the best evidence-based treatments for orthopedic injuries. So today we're going to talk about some of the treatments that came from Mayo Clinic and the latest evidence of non-operative treatments that I do for patients that really is a game changer in orthopedics and gets people back to work quicker. And those include tendon scraping, 10X, which we'll talk about, a fasciotomy, I'll just briefly talk about, it's for a rare condition, carpal tunnel surgery done under ultrasound, trigger finger releases, frozen shoulder. I'm going to really try to go over the evidence of regenerative medicine today and dispel some of the rumors and what latest evidence exists, and then the applications of diagnostic ultrasound that can be used in the clinic. So the first thing I want to talk about is tendon scraping. So this is a really great procedure that's offered for patella tendonitis, so tendon problems on the kneecap, or Achilles tendonitis. And what we do is, under ultrasound, we have a needle and a surgical tool that goes underneath the tendon, where the tendon, where there's a lot of vessels and arteries that are called neovessels that cause a lot of the pain for patients. And we actually separate the layer between the tendon and these vessels. And it's really great because we don't go through the tendon. Patients can go back to exercise, and they can go back to work significantly quicker than some of the traditional procedures that we've done before. And so in this picture, this is what you can see. We put on this special imaging to see the ultrasound blood flow, and you can see that there's all these vessels that are causing pain near this tendon. This is the patella tendon here. And so with this instrument, under ultrasound guidance, we actually get rid of all these vessels and separate that tendon from the fat pad. And that's what causes a lot of pain for patients and contribute to tendonitis. And so this is a way for us to, and because we're not going through the tendon, there's not a long rehabilitation protocol. So for most patients for tendon scraping, they can return to work in 2 to 3 weeks doing a lot of activity. Additionally, there's one more person. Additionally, if we go through the tendon, it's usually a 6-week protocol that I have. This was my research interest at Mayo Clinic. And We take them from range of motion to strength to progressive return. But most people with some of the tendon treatments I do are back to work and within 6 weeks. So the next thing that we're going to talk about was invented at Mayo Clinic. It's called Tenex, which is called a percutaneous tenotomy. I do them in the surgery center, and we offer this for tennis elbow, golfer's elbow, so tendonitis on the elbow, patella tendonitis on the knee, Achilles tendonitis on the back of the leg, plantar fasciitis, which happens to a lot of people on the bottom of the foot, and then for calcific tendonitis, so calcium deposits that go into the tendon. We'll go over some of the evidence and latest and some of the videos that explain what this is. So the basic mechanism of Tenex is what we use this tool to get rid of the unhealthy tissue while preserving the rest of the tendon structure. And this is from a science perspective, you can see how the collagen actually restores to normal when they look at it from a lab perspective. And Tenex now has been around for over a decade, and there has been over 35 articles published in many orthopedic journals showing its efficacy. And it has success rates of greater than 85%. So these are patients that did not do well with therapy, that are continuing to have pain and are limiting in their quality of life. And it can be a really great, successful, permanent treatment solution for them. And so this is what the inflammation looks like in tennis elbow. So you can see the tendons attaching the elbow, and they have, and this patient has some partial tearing and some inflammation that's happening in the tendon. And so this video will depict exactly what we do. So you can see we make a little stab incision after giving just some local. There's no general anesthesia. And then we take this tool and we go to the area of where there's injured tissue, and we remove the damaged tissue while preserving the rest of the normal tendon. And the damaged tissue will go into this tube. It works similar to how cataract surgery works. And it takes about 10 to 15 minutes to do in the surgery center. So a lot of patients ask, what is the evidence on some of these newer treatments? Well, there actually is some really good evidence. So this is a good study that came out of the American Journal of Sports Medicine, published by some of the doctors at Mayo who were part of creation of Tenex. And they showed 3-year follow-up on patients, both from an ultrasound, so imaging perspective, and from a pain and function perspective. And this is what it looked like. So this patient, the black area, they had some tendon tearing and a lot of inflammation. And then you can see the tendon healing at 3 months, at 6 months, and then 3 years. And then you can see their pain score went from a 6 to a 0 over the course of 3 years, but significantly improved over the course of several months. And then their function also improved similarly. This was a study done at Emory University that showed PRP, which we'll go over in a little bit, versus Tenex for tennis elbow and golfer's elbow, and showed excellent outcomes in both these procedures for improving pain, function, and their quality of life. A lot of people ask, well, how does this compare to surgery? And so this was a study that was done by skeletal radiology, and it showed that Tenex versus surgery, there was faster return and similar outcomes in the ultrasound guided approach versus the surgical approach. And so they compared the two groups of surgery versus non-surgery and showed great clinical outcomes. The next procedure that we're going to talk about is called calcific lavage, where patients, as you can see in this x-ray, will get large calcifications in their shoulders. This also can happen in other parts of the body, but shoulder is the most common. And it can really be debilitating for a patient. I had a patient recently that I treated for this who couldn't lift their arm above their head. And so what we do is using 10X and also the special needle technique, we take this calcification that you can see under ultrasound out, and this is what it looks like after treatment. And these are the calcium deposits that actually come into the tubes. And one patient I just treated recently for this went back to work within a week. And so this is the large calcification in the rotator cuff. And then this is me removing the calcification under ultrasound guidance. And so you can see by taking pressure, we can actually remove a lot of that calcification. This is the calcification right here. The next procedure I really think is a game changer in medicine. So my passion in medicine has been in value-based healthcare, and I worked at the Center for Medicare and Medicaid Innovation Center in Baltimore, working on orthopedic bundled care models, alternative payment models, measuring clinical outcomes, and trying to reduce unnecessary costs in the healthcare system. And this procedure was invented at Mayo Clinic that allows me to see all the dangerous structures under ultrasound and actually cut the ligament under ultrasound without any incision in the hand. And this is a video of what the procedure looks like. And so what we do under ultrasound guidance is we identify the nerve and we identify the artery. And then with no incision in the hand, we guide an instrument all the way down to the end of the ligament. And then we cut the ligament under ultrasound guidance. Before cutting the ligament, we actually expand the balloons. And once the balloons are expanded, we take the instrument and we're able to cut the ligament completely, making sure we get a thorough release of the ligament. And then we also make sure that we're not near any dangerous structures. So what is the evidence? So if you go to Mayo Clinic today, this is the procedure that people get for their carpal tunnel syndrome. They go back to work within usually a week to 2 weeks after the procedure. They have no incision in their hand. We do everything with local anesthesia. This can be done in the office, depending on their insurance. Some of them we do in the surgery center. But this is a study that showed long-term outcomes from Jefferson Hospital in Philadelphia of this ultrasound-guided carpal tunnel surgery. And it showed 1-year outcomes that this surgery is safe, less invasive, and faster recovery than traditional surgery. This was another study that was just recently published in the Journal of Hand Surgery, and it showed long-term clinical results of carpal tunnel release under ultrasound guidance. And once again, it showed that it was safe, a very effective procedure, a lot of improvements in their pain and function, and a quicker recovery than traditional surgery.
So, I'm sorry, Dr. Gruner, I have a question. With regards to the return to work at 2 weeks post this procedure, are you looking at normally sedentary positions? Are you looking at medium duty, heavy duty? What is the gauge there for, the release for the patient at this point, for them to return to work within their job duties?
Yeah, so I actually think because the procedure is not invasive as traditional surgery. I've had people that do computer desk jobs that are going back to work in 3 days. I've had people that are doing more manual work that just need a little bit more time to strengthen their hands and to allow for a quicker recovery. But because we don't make a scar in their hand, they have the complete ability to use their hands afterwards. It also, so nerves grow back 1 millimeter, 1 millimeter a day. So if you have had carpal tunnel for 15 years, it might take a month to regrow that nerve compared to someone who has moderate carpal tunnel syndrome. So it's really important to know that that's probably the rate limiting step. It's not the procedure itself, like in traditional surgeries.
Okay, so someone that drives a bus or heavy equipment, we would be looking at somewhere within a week for them to return to work full duty.
Full duty, but it depends on the severity of their injury. But
right. Understood.
Yeah.
Okay.
So I told you that my interest is in value-based healthcare, and I've been talking about this for over a decade now. But this was a study that showed that the cost savings of carpal tunnel release done in the clinic compared to the surgery center, and it showed time activity-based costing and showed a significant reduction in the cost to the U.S. healthcare system, and was published in the Journal of Hand Surgery. The next procedure that we're going to talk about is a trigger finger release. So this is where people will get locking in their fingers due to a thickened pulley that causes a constriction in their hand. And so we can actually release these with a special needle. And this is what the video looks like. So I have a needle, I'm not anywhere near the tendons, and can actually release that pulley, allowing people who have locking of their fingers to not lock up anymore. I do these in the office. It's pretty easy with just doing some local. They don't need to go to get the surgery done. And it's very successful, and they get immediate relief with their fingers.
Wow.
So the next procedure I do is for something that's rare, only probably seen at Mayo Clinic consistently, but it's called for patients who have pressure in their legs that are caused by muscles being constricted along the fascia. There's a procedure that I do called an ultrasound-guided fasciotomy. And so Tiger Woods had this recently for his leg from trauma, but this is for chronic exertional compartment syndrome, which happens to people over a period of time, and they'll have some numbness in their legs that will develop. And so we can actually, you used to have a huge incision in your leg, and you couldn't even, that incision would get infected, and there'd be a lot of complication with that incision. Now we can cut that ligament completely under ultrasound guidance. And so this is a video, the needle above the fascia and the needle below the fascia. This white area is the fascia, and I'm able to cut that ligament under ultrasound guidance. And we actually take this instrument completely underneath the skin and are able to cut the ligament. So the next topic I really want to talk about is hip and knee arthritis. We know that hip replacements are one of the most consistent, reliable surgical options that exist in the United States. Knee replacements, unfortunately, 30% of Americans are unhappy with the knee replacements. And there's a whole lot of research being put on what are the right parameters of who needs a hip and a knee replacement. And so because of the gap between physical therapy and surgery, there's been a lot of research into the newer treatment options that can be provided for patients for hip and knee arthritis. This was an article written in the Washington Post that showed that 1/3 of patients in the United States are unhappy with a knee replacement, and 20% are dissatisfied with knee replacement. And so unlike the hip replacements where we've had really good clinical outcomes, knee replacements have been lagging behind. And so what are people doing? So I was at the Harvard Business School focusing on learning about how to optimize outcomes for patients for hip and knee replacements. And they're using machine learning to look at all the predictive factors on who will be a good candidate for a knee replacement. And so they were looking at pain and function outcome measures. And so if you go into Harvard Hospital now, a patient can actually see their percentage chance of having a great outcome with a knee and hip replacement. And so this has been really helpful for making sure that we're getting the right treatment for the right patient, which is really important in healthcare. So while we're still doing that, and we're trying to find the right candidates, there's a huge void that lies between physical therapy and surgery. And that's where regenerative medicine has a place and option for it. Growing up in this area, I've seen a lot of people do a lot of not good things for regenerative medicine. And so I really want to spend a lot of time dispelling some rumors and going over the evidence that exists for regenerative medicine. And the two that we're going to talk about is PRP and stem cells. At Mayo Clinic, we were doing a lot of research on these. We sent every sample to a lab, and it was actually covered by Mayo's insurance. These are treatments that are not covered by insurance to date, but have a lot of literature, especially the ones I'm going to focus on today, and we'll go over that. So let's first just go over what these newer regenerative medicine treatments are. So first one's PRP. We take your blood in the office, we spin it down, and we get platelets. Those platelets have growth factors, and those growth factors help with healing, and they help with healing, and they help with restoring any inflammation that is in the tendon or in the joint for arthritis. Right. And so, as you can see in this blood tube to the right, what we get is the Buffy coats, and we get 7 to 10 times the concentration of platelets. And we take these platelets that have all these healthy growth factors, and we put it back into their injured area. It's really important to note that not all PRP is the same. There has been a lot of literature trying to refine this over the past 10 years. I mean, platelet-rich plasma has been around for a decade, but the specific combination is really, really important. It needs to be 7 to 10 times the platelet concentration. You have to take these neutrophils out, and how you process the PRP is really important for having a good outcome. It's just like taking any medication. How you, the quantity of that medication and what you do for that medication is really important. So PRP has been used for many conditions now. It's used for chronic tendonitis. It's using for arthritis, muscle, and ligament injuries. And the science rationale, once again, is that these growth factors help stimulate long-term growth. And it's very safe. That's the one thing that has been well-researched and shown that its safety profile has been very safe in your own body's platelets. So what is the evidence about these treatments? The first thing I want to tell you is that platelet-rich plasma does not regrow cartilage. It has not been shown to regrow cartilage. It's not like you put this medicine in the joint and boom, your bone-on-bone knee arthritis doesn't exist anymore. But it does help with pain and function. It lasts way longer than steroids, and it is believed to prevent the degradation of arthritis. So this was a study that was done in a surgical journal, and it showed PRP. They took all the randomized controlled trials for PRP, and they showed that PRP was better than hyaluronic acid, which is the gel that sometimes people put in their knee, or saline. And it looked at patients over 1 year and showed very significant improvements in their pain, function, and quality of life. And so they took all the randomized control studies and they came out with this answer. The big question I always get is, will PRP prevent me from getting a knee replacement? So this was a study that, this was another study that showed that PRP was helpful, and they looked at randomized control studies. The next study showed that PRP versus HA, and it was another study. This was done at University of Colorado by the orthopedic department, and showed that PRP helped with improving pain function, and showed that the specific type of PRP you use is really important. This study down here showed that PRP delayed the need for knee replacements. And it showed that one injection of PRP, 74% of the people actually delayed the need of a knee replacement by 1.5 years. And the median delay, so not the average, but the median was 5 years, and showed a survival of people that did not need a knee replacement of 85%. This is with patients with moderate to arthritis. This was a study that I just added to this presentation, just came out recently, that was published at Johns Hopkins in the Journal of Medicine. And they looked at PRP versus hyaluronic acid for knee arthritis. And they only looked at double-blind randomized control studies. So the research, everyone who had any type of opinion was blinded to make sure that no one knew what type of treatment that patient was getting. And they showed that PRP had significant advantages in improving pain, function, and quality of life compared to traditional injections.
So, Dr. Gruner, in the prior slide, you said 87.5% of people never needed, 85.7% of the patients did not even undergo a total knee replacement during the 5-year follow-up.
That's correct.
So did they ever have it, or did they just look at 5 years beyond the PRP treatment? And the reason I'm asking is because a total knee replacement is a huge deal. And if you are avoiding that for, 10 years, 5 years, that's pretty big.
Yeah. Getting long-term data is extremely hard. So I was really impressed with this study about how they got 5-year follow-up. Okay. But you're right. If the value to society is you can prevent someone from getting a knee replacement with 1 or 2 PRP injections for a decade, that really has a lot of meaningful improvement. It'll make sure there's a better outcome for the surgery. And so I think it definitely has a reliable role in medicine. And the evidence is just, there's too much evidence now for PRP for knee arthritis, just to be honest with you.
So for PRP, what is the injection rate? How many times can you have it, or how often do you have to have it to have sustaining results?
Yeah, so the way I do it is I do 1 injection with hyaluronic acid, because we had a registry at Mayo that showed that PRP plus hyaluronic acid did better than PRP alone. And that 1 injection, depending on what hyaluronic acid we use, but that 1 injection should last at least a year to a year and a half if they're a good candidate for the procedure, which is important to take into account. The severity of their arthritis is very helpful. I would say people with mild arthritis, it could last 5 years, 7 years. People with moderate to severe might be shorter than that. But it's significantly better than getting 3 steroid injections over a period of time. We know steroids are detrimental to the cartilage. And so it's a more cost-effective approach and a better approach, and it's healthier for the patient and safer. So there's been so many studies now for PRP for knee arthritis that they've taken all the level 1 randomized control studies and they're doing cost analysis. And this was a study done at Rush University in Chicago, and it showed that if PRP lasts 1 year, the cost of it to the society is $1,200. And so they're finally starting to do cost analysis studies on PRP because of the research has been so good. And so I'm excited about this as someone who's very interested in the value-based healthcare world, because I think this does have a role in medicine. So the next thing we're going to tendinitis. So tendinitis, we talked about for tennis elbow, golfer's elbow. The PRP for arthritis is not curative. Arthritis is a progressive degenerative disease. For tendinitis, it is curative. And this was a study that was done at Stanford University. It showed a double-blind, prospective, multi-center, randomized control study, and showed PRP didn't really show that much difference between no PRP at 12 weeks, but then they followed this out at 24 weeks, and they showed that PRP had a large difference in favoring. And this is traditionally how it works. You have more pain than you do at the injection because it causes inflammation, and then it gets progressively better over a sequential amount of time. It works the exact opposite of steroids. And these two studies showed one of them for glute tendons, so tendons on the side of your hip that people can sometimes have tendon tearing there. This was a double-blind randomized control study that was published in the American Journal of Medicine with 2-year follow-up done out of Australia, and showed excellent pain and function improvement compared to steroids, and lasted over 2 years. This was a study that was done out of Tulane University in the Department of Orthopedics, and showed that PRP was equal to surgery for medial epicondylitis, so that tendon problem on the inside of their elbow. And now there's been over 40 studies that have looked at PRP for different areas of the tendons. Some areas are good and some areas need more research, and they're not so good. So shoulder PRP has not proven out as well compared to tennis elbow and patella tendonitis. Achilles, depending on where the PRP is at. But there's been many studies that have existed now. And depending on the body, there's various outcomes that exist for patients. So we really need to, so just to sum up about PRP, we know it's effective for arthritis. We really know that it reliably can last about a year, depending on their severity. And for tendonitis, it's long-term, but we need more evidence for some areas of the body. And we need to get to a point where we're actually risk stratifying patients and figuring out what's the appropriate patient that needs these type of procedures. So the next thing that we're going to talk about is stem cells. So stem cells, we get them from, they differentiate into different cell types. And the theory, which has been proven in animal models, but has not been proven in human models, is that they can replace the degenerative tissue. And the idea is they can prevent the degradation. We get stem cells from a whole bunch of areas. The two areas that I get stem cells from are bone marrow and fat. We also, at Mayo Clinic, had an FDA phase 1 trial that we were culturing these stem cells in a lab. And then we also had a virus that we were injecting into people's knee joints. But those are not approved in the United States. The bone marrow and fat are. And these are two studies that have shown some promising evidence for stem cells. I do want to say that stem cells are definitely clearly experimental still. We definitely need more research on that. But these are two recent studies that came out. This study was a double-blind randomized control study that came out of Rothman Institute in Philadelphia. And it showed that adipose stem cell injection improved patients' pain and function for at least a year. And the improvement in pain and function was pretty extreme. So these patients actually showed not just a clinical benefit, but a superior clinical benefit. The next study showed stem cells, adipose stem cells, so stem cells that we get from your fat, and showed 3-year follow-up and showed how it was safe, it was minimally invasive, and how it prevent the degradation of arthritis. But I think that still needs to be proven out, and there needs to be more studies to really show that. In animal models, it really has shown that it can prevent the degradation of arthritis. In human models, it's a lot more challenging. And I truly think that there needs to be some more research in this area, but it can be a valid treatment for some patients. This was a recent study that showed 2-year follow-up of intra-articular stem cell injection published in the American Journal of Sports Medicine. And it showed patients' pain function improving tremendously, but needed more randomized control studies in this area. This was a systematic review done by the Department of Orthopedics at UCLA. And it showed that in this review of the literature, they said that there's strong evidence that intra-articular stem cells are safe and generate positive clinical outcomes, but more studies needed. Any of these protocols, or any of these procedures, I strongly believe that you need a rehab protocol. And it usually takes, if it's a tendon, it takes about 6 weeks to 8 weeks for that tendon to heal. If it's arthritis, most people can go back to work within a month. Well, they actually can go back to work depending on their job severity, but most people are done with the rehab protocol at 1 month. So the last thing is I'm going to talk about some of the ultrasound uses that I do and that I think are really helpful. So for the shoulder, a lot of times patients might have rotator cuff tears, or they might have biceps injuries, but we can actually see if that's the area that's actually causing pain, and I can image them in the clinic and see if that's the correct area that's causing them pain. For their elbow, we can look at cubital tunnel and see if there's an injury to that nerve. We can look at ligaments and see if the ligaments are torn. We can, an EMG is still warranted, but we can actually measure the median nerve to see if they have carpal tunnel syndrome, sometimes saving patients in EMG. For the hip, we can look at the tendons. For the knees, we can look at the tendons. We can see if the meniscus is torn or if it's extruded out of the knee joint. We can look at different nerves under ultrasound, and we can look at the Achilles tendon and plantar fascia very well under ultrasound. And so this is what it kind of looks like. So this is what a normal shoulder ultrasound looks like of a rotator cuff tendon. You can clearly see the tendon, and the white area is showing a normal tendon. And this is what a normal biceps tendon looks like. It's very compact. You can see it's white, and you can see that this is a normal tendon. This is what we see when the tendon gets injured. We see that there's tendinosis, so the tendon becomes thick. We see that the tendon is no longer small and white, but it's black and white, which is showing some tendon tearing. And then here we can see if that tendon is dislocated or subluxated out of the groove. We can also see if the tear was acute or chronic for rotator cuff. So you see how the bone is well preserved here, but this black space exists. So we know this was an acute rotator cuff tear. And I can actually push on the area and see if that tear is actually what's causing the pain for the patient. Because there's a lot of studies that have shown that not everyone who has a rotator cuff tear needs surgery. That's beyond the scope of the talk for today. So the accuracy of ultrasound compared to MRI is greater than 90%, and it's equal in sensitivity compared to MRI. And it's definitely a very useful tool for diagnosing rotator cuff tears. This is a view of an MRI where we see a Baker cyst in someone's knee. And so cysts in any part of the body, we can drain these under ultrasound, which helps improve patients' pain and function in the back of their knee sometimes. So this was a study done out of Penn State Hershey Hospital, and they said, what is the evidence of ultrasound-guided injections in sports medicine? There are, you go to Mayo Clinic today, every injection is done under ultrasound guidance. Where I grew up in this area, that's not necessarily the case. And I just want to go over the evidence that exists for ultrasound-guided injections. And they've done now studies on every joint in the body, and with most body parts, they've shown that ultrasound was more effective than blind injections. So using ultrasound guidance to get to the right area was accurate and more effective than traditional injections. And they've looked at all different parts of the body. The last study I really want to talk to you, because as you can see, ultrasound is a very important part of my practice, and I think it has a lot of important roles in medicine. This was a study, 10-year study, or 12-year study, where they did at Mayo Clinic, and this changed the way we practice medicine at Mayo Clinic. They took half the group, got an ultrasound-guided hyaluronic acid injection, so that gel that we inject in the knee, and the other group got blind knee injections. So they were done by a surgeon, a blind knee injection, and they followed them out for 12 years. And the people who had the ultrasound-guided hyaluronic acid injection, they were surgery-free from a total knee replacement by 5 years longer than compared to someone who had a blind injection. So it really matters for both accuracy and effectiveness of using ultrasound to guide the injection to the right area. So I want to thank you guys for letting me talk today. I'm a fairly new provider to the practice here, coming from Mayo Clinic, and I really appreciate you guys giving me the opportunity to talk today. So I'm happy to answer any questions.
I have a question. So with the needle ultrasound guided treatment, the procedure that you do in the office, has there been any, or did I just miss it, discussion about using it for, say, a frozen shoulder or releasing that instead of doing a manipulation under anesthesia?
So manipulation under anesthesia, that's a great question. So I do this frozen shoulder injection. First of all, I think frozen shoulder is very tough to treat. I do a capsular distension, which has good evidence. I didn't bring up the studies for that today, but has very good evidence and is way better than the surgery under anesthesia. The honest answer, so just briefly about frozen shoulder, if you do nothing for frozen shoulder, it will resolve in 2 years, traditionally. I personally think that that's not necessarily always the case. One of the procedures that I offer is a capsular distension. So I actually put fluid in their shoulder capsule, and I break up their capsule, and then I do some soft manipulation, and then I have them work with a therapist immediately afterwards. And I've had really good clinical outcomes. I actually have some videos of good patient testimonials of me doing that. I do think that it depends where we get them in the freezing process matters. And then also understanding that frozen shoulder is a very challenging condition. So it depends on what is the cause of the frozen shoulder. But it definitely is a better option than surgical manipulation.
Okay, thank you for that.
Dr. Gruner, you mentioned that, here in our area, meaning the DC metro area, that not very many people were using this ultrasound technique for better outcomes. I mean, I hear physicians all the time talking about how progressive our area is. We have Johns Hopkins, we have NRH, we have all these places. If this is so much more productive and cost effective for patients, why don't we see more physicians using ultrasound guided techniques?
It's a really good question. I presented a lot of the literature. I can tell you what's done at Mayo Clinic, Stanford, Harvard. I'm very close with a lot of the doctors at Johns Hopkins. I'm also credentialed at Sibley Hospital. And I think it's kind of confusing to me, to be honest with you. I mean,
they have their own workers' compensation. They have their own workers' compensation program there. They have a whole huge program for workers' comp. You would think that if they had an opportunity to return patients to work sooner at maximum medical improvement, they would want to take advantage of that. It's just odd.
It's really odd. I would say Johns Hopkins in this area is probably the most progressive. And I've been having a lot of conversations with them. I also talked to Care First, and they're very interested in value-based healthcare. But I would say that this area is a lot slower than other areas around the country, and that's pretty evident at this point.
Thank you. Do you have any other questions for Dr. Gruner?
I have a question. What do you say to the commission? Because the PRPs are, the commission, Maryland Workers' Comp Commission, considers those experimental treatment. And most of the time I have been seeing those are denied by the commission. So, I think a lot of the problem is you have to change the commission's mind when regarding those type of treatment, honestly.
Yeah, I think the studies for PRP are just, there's too much evidence now. It's I told you this was covered by insurance for Mayo's employees. Mm-hmm. I don't understand why. Usually, just my time working at Medicare, usually what happens, they want to see lots of studies. They want to see that they're well done randomized control studies. Then they want to see cost effectiveness studies. And then at some point, they, insurers will start covering these things. I think the problem is that PRP is your own body. So there's not a pharmaceutical company trying to make a profit on this. So you don't have a lot of people going to the commission trying to figure it out. That's my only guess. But I know it's a struggle in the community still.
So Roxanne, one thing that our program has always been known for is being leaders in all types of care for our patients and finding the best possible care. So, it would be really up to us as a claims team and a program to determine whether or not experimental procedures, what the commission might consider experimental, would be something that is warranted for the patient and could, provide them with an excellent outcome. And now we have a resource in Dr. Gruner to help us figure that out.
Well, and that's a good thing, because our other IME doctors that I've seen, Teresa, they still say that it's experimental treatment in those reports.
Well, we'll talk to Pearl about how we can use Dr. Gruner in some of those situations.
Okay.
Dr. Gruner, Pearl Monroe, as you saw in our emails, is the program director for MC Innovations and our guiding hand in some of this type of work where, we want the best outcomes for our injured workers, but the treatment or maybe the specialty is like you say, it's a journey, and making those steps. Sometimes we just have to go out on a limb and see where we are. So actually, Roxanne, that's a very good point that we can make with Pearl.
I appreciate that. Willing to help you guys out in any way, shape, or form.
Do we have other questions out there for Dr. Gruner? All right, well, Dr. Gruner is going to share his presentation with me, and I'm going to post that on our SharePoint site. So if anyone wants to go back and take a look at it, or if they need information about these techniques, it'll be there for us to have in the future. And his contact information is here, so we'll have that as well. Dr. Gruner, thank you very much for some really great information and some eye-opening studies and treatment that we can use as options for our injured workers.
Thank you so much, Teresa. I really appreciate it. It was an honor and privilege to talk with you guys today. So thank you so much.
All right.
Thank you very much.
Thank you.
I appreciate it.
Bye.